Starting this year, 2026, Medicare will begin financially rewarding hospitals for spending less money on your recovery after surgery. And most Medicare beneficiaries have never even heard about it. Medicare is launching two major programs called TEAM, T-E-A-M, and ASM. Officially, these programs are supposed to improve coordination, improve outcomes, and reduce wasteful healthcare spending. And this is a new payment system that will replace the current fee-for-service structure of original Medicare. In my opinion, the financial incentives structure of this new program has a high probability of leading to lower quality and lower quantity of health care. I see too many similarities with the same financial incentives that gave us prior authorizations for Medicare Advantage plans. I'll give you the details on why that is the case in just a moment. By the end of this video, you're going to see exactly why this new system rhymes with something we all dislike about Medicare Advantage plans. You'll want to hear what I have to say because Medicare is not sending you a notice on this. So first, I want to explain exactly what the new TEAM and ASM programs are and how financial incentives that they have in place will work, and why Medicare, of course, is implementing these programs. And why is it that some critics, myself included, are concerned these systems could eventually create pressures very similar to what many people believe has already happened inside Medicare Advantage managed care. To understand TEAM and ASM, you first have to understand how Medicare has traditionally paid for health care. Understanding the old system is what makes what's coming so alarming, so stay with me for just 30 seconds. For decades, original Medicare mostly operated under a fee-for-service model. Under that system, hospitals, doctors, therapists, medical providers were generally paid for each service they performed. Every office visit generated revenue. Every scan generated revenue. Every lab test and therapy sessions generated revenue. Every additional procedure generated revenue. Medicare believes that system unintentionally encouraged a higher volume of services because more services often meant more money flowing into the system, and I believe it did. When more services results in higher income, the incentive can result in unnecessary services. It is also a payment structure that promoted fraud, or at least made fraud easier to get away with. CMS, which is the Center for Medicare and Medicaid Services, has spent years trying to move healthcare towards what they call value-based care. Instead of rewarding volume, Medicare now wants to reward efficiency and outcomes. The idea sounds great and simple in theory. Medicare wants hospitals and related care focused on whether patients actually improve, not simply on how many billable services were performed. And on paper, that sounds very reasonable. Most people would agree that healthcare should be coordinated, should be efficient, and focused on outcomes, not volume. The problem is that once financial incentives are attached to reducing costs, the system begins creating pressure to reduce spending. Sometimes that reduction may truly eliminate waste, but other times the easiest path to lower spending is to simply provide less care. And that brings us to the TEAM model. TEAM stands for Transforming Episode Accountability Model. It officially began January 1st, 2026 and is currently scheduled to continue through the end of 2030. TEAM focuses primarily on several major categories of surgery, including hip replacements, knee replacements, spinal infusion procedures, coronary artery bypass surgery, and major bowel procedures. Under the traditional Medicare system, many different parts of a surgical recovery process are all billed separately. The hospital bills Medicare, the surgeon bills Medicare, the physical therapist and occupational therapist bill Medicare, your skilled nursing facilities bill Medicare, rehab bills Medicare, follow-up bills, your follow-up visits are all separate Medicare bills. Everything is a la carte. Even complications and readmission also create additional spending or income to the hospital. Under TEAM, Medicare instead evaluates the entire surgical episode together as one unit of care. Technically, the official team episode begins with the inpatient admission or outpatient surgical procedure itself and continues through 30 days after discharge. During that 30-day post-discharge window, Medicare evaluates the total cost of the patient's recovery episode. And that includes hospitalization, rehab, follow-up care, readmissions, complications, and everything else connected to recovery after surgery. Medicare then compares the total cost of that episode to a target spending amount that they have established. If the hospital and providers keep their spending below that target amount while still meeting quality standards, they may receive a bonus payment or financial reward. But if the hospital spending exceeds the target amount, the hospital may owe money back to Medicare. And that changes incentives dramatically. And what that means for you is the hospital's now financially rewarded for spending less on your recovery, and there's no external oversight telling them to stop. Under a fee-for-service system, additional services increase revenue. Under TEAM, additional spending can hurt financial performance by reducing profit margins. Hospitals are no longer simply thinking about how to provide care. They're also thinking about the total cost of the recovery episode. Now, technically, the official TEAM episode begins with the surgery itself and then the 30-day recovery period afterwards. However, this is where something very important begins happening behind the scenes. Even though pre-operative care is not formally included inside that 30-day episode window, hospitals are already being encouraged to redesign pre-operative care pathways in order to improve the financial outcomes under the TEAM. Why? Because hospitals understand that patients who are healthier and better prepared before surgery often recover more efficiently afterwards. And that means that hospitals may increasingly implement standardized prehab or pre-op care that involves the preoperative physical therapy conditioning programs. In many cases, that could absolutely improve outcomes. Better preparation before surgery can lead to fewer complications afterwards. But critics worry that once these systems become heavily protocol-driven and financially focused, hospitals may increasingly steer patients into standardized pathways designed primarily around cost efficiency. In other words, the system may gradually move towards the cheapest acceptable pathway instead of the most individualized and optimal pathway. Why? Because it's easier to measure a dollar saved than the quality of life after care. To be clear, the biggest impact may not occur during surgery itself. Now, most people hear about TEAM and assume the operation is where the cost-cutting procedure occurs. In reality, surgery itself may remain relatively unchanged because hospitals and surgeons still want successful surgical outcome. The larger financial pressure will likely emerge in the preoperative and postoperative portions of care. Think of it this way. From Medicare's perspective, the surgeries and related care are inefficient, and there's no incentive to improve efficiency under a fee-for-service structure. Medicare's solution is to define surgery and all the related care as one unit called an episode. Medicare then pays the hospital a fixed payment for an episode. If the hospital and related services are efficient and their cost is less than what Medicare pays them, they keep the difference. The more the hospital can reduce their costs, the more profit per episode. And if you thought this only applied to surgery, it doesn't. In 2027, this same financial pressure is going to hit your cardiologist, your oncologist, and your kidney doctor. Because the second major Medicare program introduced is called ASM, which stands for Ambulatory Specialty Model. Unlike TEAM, which focuses heavily on surgical episodes and recovery periods, ASM is designed around outpatient specialty care. Now, CMS plans to begin ASM in 2027, and the model focuses on specialists managing chronic and complex medical conditions outside the hospital setting. That includes areas like cardiology, oncology, nephrology, pulmonology, gastroenterology, and other high specialty care fields. Just like TEAM, the goal is to improve coordination, improve outcomes, and reduce unnecessary spending. Under ASM, specialists and healthcare organizations may increasingly be evaluated and financially rewarded based on the total cost and efficiency of patient management instead of simply the number of services performed. In theory, supporters believe this encourages doctors to prevent complications, avoid unnecessary testing, reduce hospitalizations, and manage chronic disease more effectively. But critics worry the same financial pressures that we discussed with TEAM could eventually emerge inside outpatient specialty care as well. Once financial rewards become tied to reducing overall spending, the system can gradually create pressure to limit referrals, reduce testing, shorten treatment pathways, or steer patients towards lower-cost treatment options. These programs will impact far more than just hospitals and surgeons. TEAM and ASM potentially involve nearly every major category of medical health care connected to a patient care and recovery. That includes hospitals, surgery, anesthesiology, primary care, specialists, radiology, physical therapy, occupational therapists, home health care agencies. In many ways, these programs are not simply changing how one doctor gets paid. They're changing the financial structure surrounding the entire healthcare ecosystem involved in Medicare patient care. I believe what we will see at first is a strong push to increase efficiency, and that will come from the care structure first, and then from technologies. The TEAM structure incentivizes hospitals to implement new technology that, in the long run, reduces their cost per episode. For example, hospitals are increasingly adopting AI in radiology to improve efficiency and lower labor costs. Now, while many experts believe AI will assist rather than replace radiologists in healthcare, healthcare systems clearly expect AI to reduce staffing and allow fewer people to process imaging work. In fact, the CEO of NYC Health and Hospitals, the largest public hospital system in the United States, was quoted in an Economic Times article that he's prepared to begin replacing radiologists with AI once the regulatory landscape catches up. Every dollar saved on imaging goes straight to the hospital's bottom line under TEAM. And that incentive doesn't care about your diagnosis. If you simply go online and research how AI can improve hospital care efficiently, you get a long list of services impacting every department. Then all are expected to be implemented in just the next few years. So Medicare's new TEAM model will simply motivate and speed up the transition and AI implementation. But here's the point the model does not plan for. What happens after efficiency is maximized? Efficiency alone will eventually have diminishing marginal returns. There'll be a point soon where that marginal benefit to the hospital is not worth the additional expense. That point can happen very quickly and is where I am concerned about this model turning against the patient. Once efficiency is maximized, the greater marginal returns to the hospital will come from reducing the quality or quantity of patient care. Hospital admins will encourage doctors to adjust their recommendations. Perhaps fewer people will qualify for preoperative care, or post-op care will have a maximum number of visits regardless of the need. Or maybe the hospitals will contract out those services to the lowest bidder, who themselves cut costs by hiring the less qualified employee. For example, hospitals may begin asking questions like this behind closed doors. Does the patient really need this many physical therapy sessions? Can discharging happen sooner? Or maybe we can send them home one day earlier. Can home health care visits be reduced? Can rehabilitation be outsourced to a lower cost provider? Those questions may sound reasonable from a business perspective, but they also demonstrate how financial incentives can gradually influence medical decision making. And this is where critics begin drawing comparisons to Medicare Advantage. Medicare Advantage plans receive fixed payments from the government and therefore benefit financially when overall spending is controlled. That's why they introduced prior authorization requirements. The original argument was that prior authorizations help the insurance company control wasteful healthcare spending. But the use of prior authorizations quickly devolved into a tool to limit care as a method of increasing profit margins. With the TEAM model, prior authorizations can be replaced by a hospital administrator setting healthcare policies for all medical staff. The pressure against quality care is then an internal corporate pressure instead of external prior authorizations. Hospitals are businesses. Large healthcare systems answer to budgets and margins and operating performance and financial targets. Administrators are constantly looking for ways to reduce cost. Once Medicare creates direct financial incentives for lower episode spending, hospitals may increasingly seek lower cost vendors, reducing the quality of care, and set hospital policy that keeps the quantity of care at a minimum. And this is one of the major concerns surrounding value-based care systems generally. Quality does not always decline dramatically and visibly. Sometimes it declines quietly and gradually, which I think will happen here. Patients may still technically receive care, but they may receive less individualized attention, less aggressive rehabilitation, fewer therapy sessions, shorter follow-up periods, and more standardized recovery pathways. Meanwhile, the spreadsheets may show improved financial performance and lower costs. Am I crazy? Is there something to be worried about here? If you see the potential similarities between the team and ASM models and how they can become like Medicare Advantage plans, let me know in the comments below. How do you feel about what Medicare is doing? And should they have provided a better notice? To be balanced and fair, supporters of team and ASM would argue that the current healthcare system is financially unstable. They would argue there truly is waste in the system. And they would point to unnecessary spending, duplicated testing, fragmented care, avoidable complications, poor coordination between providers, and a massive amount of fraud that's incentivized by the fee-for-service system. They would say these new models encourage providers to think more holistically about patient outcome and recovery instead of simply generating billable services. And again, some of that is absolutely true. The real question is not whether healthcare should become more efficient. I think we would all agree that it should. The real question is whether Medicare can successfully reduce waste without gradually reducing necessary care. And that is a balancing act that I'm concerned about. Because once financial incentives are tied to lowering costs, institutional behavior changes. Administrative behavior changes. Financial behavior changes. And eventually, medical behavior can change too. Maybe these programs succeed exactly as Medicare hopes. Maybe they improve coordination, reduce complications, eliminate wasteful spending, and improve outcome for patients. That's absolutely possible. But consumers should also understand the potential unintended consequences. As I said in a recent video, managed care is a friendly way of saying managing costs. And managing costs usually devolves into lowering the quality and quantity of care. Systems financially rewarded for lowering spending may eventually normalize providing less care, especially in areas where the patients may not immediately notice, like rehabilitation, physical therapy, home health care, follow-up care. As I said, it's much easier to measure a dollar saved than the quality of care a patient has, the quality of life a patient has after care. If that happens, the true and long-term cost savings may not come primarily from eliminating waste. They may come from reducing the overall quantity and intensity of care itself. That is the central concern surrounding the new teams and ASM Medicare programs, and it's something every Medicare beneficiary should begin paying attention to now, because these programs are no longer theoretical. They're already here. Now, you've heard both sides. I want to know which side you're on. Please tell me in the comments below. I'm going to link below where you can search on Medicare and what hospitals, what organizations are required to follow the new teams and outpatient methods. If you found this video helpful, I'd really like to hear your thoughts in the comments below. Do you believe these programs will truly improve your health care? Or do you worry they could eventually reduce the quality and the quantity of patient care? I read the comments, and I'm very interested in hearing your perspective. And also, please click the like button, because that helps the YouTube share this information with more Medicare beneficiaries. And if you haven't already, subscribe to this channel. if you want more in-depth analysis on the future of Medicare and how these changes will impact you and your family. I'm Matthew Clausen with Medigap Seminars, and I'll see you in the next video.